Hello, I'm Michael Pinsky, and this is a lecture on assessing tissue perfusion. My conflicts of interest are shown here, and they have nothing to do with what I'm going to discuss. What is the optimal perfusion pressure of the tissues? Well, that's the perfusion pressure that allows regional blood flow to those tissues to be autoregulated based on what that individual tissue's metabolic demand is. Below that level, the pressure threshold is lost, and they have only flow relative to pressure, and that causes ischemic organ dysfunction. The other name for ischemic organ dysfunction is circulatory shock. So hypotension is a medical emergency. It must be stopped. Is there any magic threshold value of hypotension? No. In this large study of over 8,000 patients with septic shock, from the Cleveland Clinic database, you can see that the odds of mortality increase progressively as your mean arterial pressure falls from 85 to 75 to 55, and acute kidney injury, AKI, also goes up as well. There is no threshold value above which they are constant. Okay. And furthermore, it isn't the pressure itself, it is the duration of time. I can be hypotensive for 10 seconds and it won't matter, but if I'm hypotensive for an hour, it's a very big deal. So mortality and morbidity increase with the duration of time that a patient is hypotensive for any given level of hypotension. And furthermore, in a large meta-analysis of the impact of hypotension on mortality across multiple studies, you can see that there is approximately a 50% increase in mortality and incidence of acute kidney injury in patients who have hypotension. It's a big deal. To address this issue, a few years ago, OSFAR from the French group studied a high blood pressure, which they targeted at 80 to 85, versus a low blood pressure of 65 to 75. And as you can see here, the two groups separated. However, also note that the low blood pressure group really was at 75, not 65. The number 65 isn't even on this graph. What did they find? Well, they didn't find, as two groups as a whole, any difference in mortality, whether you had high blood pressure or low blood pressure. However, when they did a predefined subgroup analysis of the patients in the middle of this graph, they were looking at patients with pre-existing chronic hypertension. If you had pre-existing chronic hypertension and you were in the low blood pressure target, you had a statistically significant higher incidence of an increase in creatinine and a statistically higher incidence of the need for dialysis. So end organ dysfunction occurred more often in patients with previous hypertension who were treated with a low blood pressure target. Why don't we get everyone to have a high blood pressure target? Well, the complication rates were greater in those patients who had a higher blood pressure, suggesting that it's a problem. And in fact, when this was looked at in a group of combining the two groups together, the SEPPAM study, which was the OSFAR one, plus the ovation, you can see that the primary determinant favoring a low blood pressure versus a high blood pressure target occurred if you had to be on vasopressors for more than 6 hours. They had a significantly higher 28-day organ dysfunction and a significantly higher 90-day mortality. Thus, if you're going to give norepinephrine to increase blood pressure to avoid hypotension, you do it early and you try to get it off soon because it'll only decrease quality of life. Okay. Importantly, if in that study you looked at the ratio of a 28-day mortality relative to age, you can see the older you were, the more you couldn't handle a high blood pressure, presumably because your left ventricle can't handle the increased afterload. If you're young, you can do well. And the threshold value for which this happened was at about 56 years of age. And that's about half your patients will be above that age. And so you should be very careful about trying to give high blood pressure medicines to older people independently of assessing organ blood flow. And that's why we said a few years ago that we wanted to have a personalization of hemodynamic management of septic shock and not to use specific guidelines for everyone. And in this regard, I'm specifically mentioning the surviving sepsis guidelines. If we go back and figure out what is the determinants of blood flow and arterial pressure, we see, is shown by Milnor here in 1982 in his textbook, that the arterial pressure shown on the top panel, going from the aorta to the large arteries and then falling quickly in the arterioles, precapillary sphincters, the mean arterial pressure is relatively constant, and then the pressure drops rapidly. Therefore, though there is no such thing as systemic vascular resistance because there's not a linear decrease in blood pressure, there is a total peripheral resistance, which is mainly mean arterial pressure divided by cardiac output. What you can see is arterial resistance is not uniformly distributed across the arterial tree because all the resistance is in the small arteries and arterioles because that's where autoregulation occurs. Arterial pressure does not drive cardiac output. Okay? When we looked at this in human beings, we put in a catheter into the aorta, and we also put it in a flow probe on the aorta during cardiac surgery and put our finger on the inferior vena cava and showed that as aortic flow decreased, arterial pressure fell. And in a human being, if you were to plot the stroke volume versus pulse pressure and you extrapolate it down, you would see that we generated a zero stroke volume with still having a measurable pulse pressure. So that is the critical closing pressure. The slope of the line is resistance, but more importantly, this means that you have a vascular waterfall. That critical closing pressure is much higher than central venous pressure. And furthermore, tissue perfusion pressure is mean arterial pressure minus critical closing pressure. And in anesthetized humans, as you can see, it's about 20. In you and I, it's much higher. So we looked at this in post-op surgical patients using the inspiratory hold technique that allowed us to measure cardiac output and CVP at 3 or 4 different levels of CPAP. And you can see we calculated on the right side the mean systemic filling pressure. In this example, it was 20. And in the same patient, at the exact same point, we also had their mean arterial pressures, the same cardiac outputs, of course. And so we were able to calculate the ventricular function. And you can see in this patient, its critical closing pressure was approximately 36. More importantly, that's the vascular waterfall, the difference between the critical closing pressure and the mean systemic pressure. That's what is needed to maintain autoregulation of tissue blood flow to each organ. And it turns out to be approximately 35 to 45 millimeters of mercury. And you can calculate it using the app iGuidon, which we created and is available free of charge for both Android and Apple phones. So what is a vascular waterfall? Well, a vascular waterfall means that the rate of flow of water is independent of how far it falls after the edge. This is Victoria Falls in Tanzania. And as you can see, the amount of water going over the edge is totally independent if it fell for 10 meters or a kilometer. It would not go over the edge any faster. All of the determinants is the upstream pressure to the edge of the waterfall. And by the way, that's me. So if we looked at the specific organs, we see something different. Let's take the brain. If it's totally dilated, I need very little pressure to increase flow. And if it's very constricted, I need a whole lot of pressure to increase flow. So let's see what happens to the brain if I have a very high perfusion pressure and I allow it to fall. I see a very strange phenomenon. First of all, at very, very high pressures, the flow is very high to the brain and is determined by perfusion pressure. And this is why malignant hypertension causes cerebral edema. But after a point, when you're below the maximal constriction possible, even though the perfusion pressure falls as mean arterial pressure goes down, blood flow remains constant. And this is the autoregulatory range. And the way this happens is that the vasculature dilates up its resistance vessels to maintain flow constant until it gets to some minimal level. And at that point in time, if it goes below there, you're in shock. So as a critical care doctor, all you want to do is be above that point. What is that point? Well, in you and I, it might be around 65 millimeters of mercury, but as I showed you from OSFARs in patients with essential hypertension, the curve is shifted to the right. How much is shifted, I don't know. And what about individual organs? If you were to look, as David Kramer did in our laboratory, at renal, gut, and liver blood flow instantaneously during an occlusion so that the pressures of flow fell very rapidly, you would see that they have different resistances, the liver high, the kidney the low, and the gut in the middle. And furthermore, they have different critical closing pressure. The liver has almost no critical closing pressure because it drains into sinusoids. But watch, if I have a given mean arterial pressure, and all that happens is I get transient hypotension, I will see a disproportionately greater decrease in kidney blood flow than gut and liver. And this is why systemic hypotension causes acute kidney injury. And this is also why systemic hypotension rarely damages the liver. So there are multiple waterfalls. What happens in sepsis? Well, we showed years ago that if you take an animal and give them acute endotoxemia, within less than a half an hour, their mean systemic pressure, their critical closing pressure falls, but their resistance doesn't change. After about 3 hours, endotoxin causes the inducible nitric oxide synthetase to vasodilate the resistance vessels, and the slope of the line goes up. But in both cases, the critical closing pressure falls rapidly. And as David Kramer showed in our study in our animal model, if we then gave these animals endotoxic shock, you can see that the vessels became more homogeneous in their resistance. Now, that means that in sepsis, unlike under normal conditions, organ blood flow will change proportionally to changes in mean arterial pressure. And that's good if you're a critical care doctor, because in the setting of septic shock, giving vasopressors like norepinephrine should increase blood flow across all the organs as opposed to just universally to one, specifically to one or another. So let's go back to my picture I showed you before, in which we show the ventricular pressure-flow relationship, which gives us critical closing pressure, and on the left, the mean systemic curve. And there is our tissue perfusion pressure, just as we said before. But remember I showed you that in septic shock, I can have a shift of the curve. What if that curve is so much so that the critical closing pressure is almost identical or is identical to mean systemic pressure? Well, if that's the case, and I then vasodilate, even if I have a normal mean arterial pressure, I will see no increase in organ blood flow. Does that happen? Well, yes, it does. In a study using post-cardiac surgery vasoplegia, which is a nice model of vasoplegia, the group from Gano showed that if they measured critical closing pressure, mean systemic pressure, CVP, and mean arterial pressure in all 30 patients, and they calculated the mean arterial pressure to critical closing pressure, tissue perfusion pressure, and the vascular waterfall as critical closing pressure minus mean systemic pressure, that they were able to see how norepinephrine helped. So they gave all their patients norepinephrine to increase their mean arterial pressure from about 59 to 80. And what did they find? Well, they found that in the patients in whom the vascular waterfall increased, those are the ones on the right, which was about half of them, they had an increase in tissue function, whereas the ones on the left had the same increase in mean arterial pressure and no change in organ system function. The improvement in tissue perfusion parameters only occurred on the left if you improve the vascular waterfall. And that can be documented by a greater decrease in lactate, a decrease in capillary refill time, and when measured, increased in microcirculatory flow under the tongue. Sandra then said, well, I can calculate critical closing pressure in patients, and in about 6,000 ICU patients using machine learning, he created an algorithm to calculate in real time critical closing pressure. And then he was able to determine mean arterial pressure minus critical closing pressure in a whole bunch of cardiac surgery patients. And what he found was the optimal mean arterial pressure was greater than 74 millimeters of mercury in these post-cardiac surgery patients. If it was less than that, they had more time in the ICU and a higher mortality. Furthermore, the magic number for tissue perfusion in his group of patients was 34. If the tissue perfusion pressure was greater than 34 with treatment, those patients did well. If they didn't, it was bad. And the critical closing pressure that they were looking at turned out to be greater than 40 millimeters of mercury. And recall that in you and I, our critical closing pressure is 45. So let's go back and look at OSPHAR's data. Look at their lower pressures. They actually were at 75. So they were at the same level. Their data agrees with that of the group of the cardiac surgery patients. So there might be a universal truth here. It's good to be at the edge of the vascular waterfall. So what drives tissue perfusion pressure? It's definitely not mean arterial pressure unless you're profoundly hypotensive. Is it cardiac output? No, because cardiac output is determined by the tissues. The cardiac output doesn't drive the tissues. Is it due to local metabolic demand? Of course, that's the whole reason you have the circulation. And is it blunted by severe injury, sepsis, and surgical trauma? Usually. So in conclusion, initial shock management is with a fluid bolus to get cardiac output up, but if the mean arterial pressure stays below 35, you should immediately start norepinephrine to restore mean arterial pressure and then assess end organ function. If end organ function is not good, you can increase mean arterial pressure with more norepinephrine to about 75 to 80 to see if it makes them better, but you need to assess capillary refill time and lactate clearance to make sure it's the case. If you see no improvement with the increase in arterial pressure, go back down to 65. And importantly, both critical closing pressure and mean systemic pressure can be calculated at the bedside if you know CVP, cardiac output, and mean arterial pressure. The microcirculation is more responsive if you have a restored vascular waterfall when you increase mean arterial pressure than not. Thank you for your attention.